Greetings to all, and thank you for taking the time out of your day to join us for our program on brain health, wellness, and aging. And I want to give a big thank you also to Dr. Mather and Dr. Weintraub for taking time out of their day to share with us their research on the brain. And I also have to thank Dr. Charles and the library's health services team for continuing to offer health-related programs for library staff and the public. So I'm JJ Harpster. Hello. I'm head of the science section in the library's science and business reading room, which is located on the 5th floor of the John Adams building on Capitol Hill. We're also available online via our website in our Ask a Librarian service. So as head of the science section here at the library, I lead an amazing group of science librarians who develop print and digital collections. They provide reference services, they create research products and programs. My section mainly deals with the library's general collections, which are print and monograph journals that are published after 1800 that are not deemed rare and special, but I always say don't tell them that because I think all of our material are special. The Library of Congress has one of the largest, most diverse collections of scientific and technical information in the world. Such materials make up roughly 1/4 of the library's collections, or about 7 million items, books, pamphlets, serials. We collect worldwide, with the majority of the collection being in English and other European languages. The library collects intensively in all areas of science and technology, with the exception of clinical medicine and technical agriculture, which are subject specialties of the National Library of Medicine and also the National Agricultural Library. However, the library does collect works in health and medicine fields with a focus on public, consumer, and global health, and also the history of medicine, in which we are very strong in. And in recent years, as the libraries attempted to meet the expanding needs of Congress and our researchers grappling with all this new and increasingly complex health and medical issues and all the new technologies, that many of our clinical texts that we once did not collect, we are collecting now. So we're really focusing on material in the areas that relates to diagnosis and treatments. So we are collecting more of that stuff now than we ever did. The Library of Congress also holds one of the largest and most accessible collections of technical reports in the world. The number of documents held by the library run into the millions, of which about 5 million are housed on hard copy, microfilm, or digital media. So I will end this science section introduction that the Library of Congress is a library for all, and we encourage you to visit us on Capitol Hill or online. So I'll turn it over to you, Dr. Charles.
Good afternoon. I'm Dr. Sandra Charles, Chief of the Library of Congress Health Services Office and Chief Medical Officer. I first want to recognize and thank our dynamic health services wellness trio of Colleen Rogers, Nia Miles, and Carrie Moore for coordinating this webinar. And I thank JJ Harpster of the Science section for her support and co-sponsorship of the program. It is now my distinct pleasure to introduce our distinguished speakers from Northwestern University Feinberg School of Medicine. Molly Mather, PhD, is an assistant professor of psychiatry and behavioral sciences in the Mesulam Center for Cognitive Neurology and Alzheimer's disease at Northwestern University Feinberg School of Medicine. Dr. Mather obtained her bachelor's degree from Pomona College and PhD in clinical psychology from University of Massachusetts Amherst. She completed fellowship training in neuropsychology at the Mesulam Center and is currently a clinical neuropsychologist at the center at the Neurobehavior and Memory Clinic of Northwestern Medicine. She has been involved in aging research for more than a decade, ranging from tip-of-the-tongue experiences and emotional functioning in healthy older adults to neural markers of neuropsychiatric symptoms in early Alzheimer's disease dementia. Her current research interests focus on characterizing longitudinal cognitive aging trajectories, including both dementia syndromes and cognitive superaging. Our next speaker, Sandra Weintraub, PhD, and a member of the American Board of Clinical Neuropsychologists, a member of the Board of Professional Psychology, and a fellow of the American Academy of Neurology. Is professor of psychiatry and behavioral sciences, neurology and psychology at Northwestern University Feinberg School of Medicine. She is an alumni of McGill and Boston University and was on the faculty at Harvard Medical School prior to joining Northwestern. She has been the director of the clinical core and now also associate director of the Alzheimer's Disease Research Center, funded since 1996 by the National Institute on Aging. This NIA-funded Disease Research Center is a component of the Mesulam Center for Cognitive Neurology and Alzheimer's Disease, where she's also a researcher and clinician. She is board certified in clinical neuropsychology. She directs the outpatient clinical neuropsychology service at the Neurobehavior and Memory Clinic of Northwestern Medicine, a multidisciplinary clinic dedicated to state-of-the-art diagnostic, treatment, and research resources for patients with dementia and their caregivers. She has been involved in creation of data collection methods for Alzheimer's disease and also was a member of 3 special work groups to redefine criteria for the clinical diagnosis of dementia of the Alzheimer's type. The clinical diagnosis of behavioral variant frontotemporal dementia, of which we've heard quite a lot in the news recently, and the clinical diagnosis of primary progressive aphasia. Dr. Weintraub has co-authored over 300 publications on the neuropsychology of dementia, healthy cognitive aging, and aphasia. Her main research interests lie in the clinical, genetic, and neuropathologic aspects of brain and cognitive aging, including the unusual superaging trajectory. So, without further ado, I will present our speakers who will show that we were not lying when we titled this event, Brain Health, Wellness, and Aging. Hear from the experts. Here are 2 experts for today. Thank you.
Thank you so much for having us. I'm going to take the lead on going through sort of some content information relevant to what we want to talk about today. And Dr. Weintraub is on inpatient service, covering inpatient service this week, so she might have to pop in and out, but she'll be here to help answer questions a little later on. So just starting out, no relevant disclosures from myself or Dr. Weintraub for today. To give an overview of what I'm going to cover, we want to start with talking about what we think of as kind of normal cognitive aging. So, what is typical for people as they age. We'll talk a little bit about what we've at the Mesulam Center studied with superagers and cognitive superagers, which is really fascinating. And then we'll talk a little bit about, what individuals can do to promote brain health generally as they age. So we'll start just by talking about cognitive aging in general. So our brain, we can think of it as kind of a busy factory. It produces thoughts, language, memory, things like personality, behavior, and emotion. Really anything we experience or do is really a result of brain functions. Different parts of the brain are responsible for different types of brain function. So you can see on the image here that, different types of cognitive abilities are kind of localized to different places, but most of the things that we actually do during the day, the more complicated cognitive activities and our daily activities are a result more of kind of communications between different networks of the brain. So it's a lot of different parts of the brain working together and having to really kind of work as a team to make anything happen for us. So cognition obviously changes over the lifespan. Babies develop and grow, their cognition becomes better as they get older. This continues to improve into adolescence and young adulthood. Different functions, different types of functions do have different sort of trajectories over time. So let's look a little bit at kind of specifically what things might change with aging. So certain types of cognitive abilities do seem to kind of peak in the 20s and 30s and then gradually decline over time. That's things like processing speed, working memory or complex attention, learning and remembering new information. Those are things that tend to, show some pattern of decline over time when you look at big groups of people. I will say that on this graph in particular, it looks like a rather steep or dramatic decline. This is just a function of the way that the numbers are spaced. It's, a bit more of a kind of steady, subtle decline over time. And what this graph also shows is that there are certain abilities that actually, really don't have this typical pattern of decline into older adulthood. So things more like knowledge. So that can be just knowledge about the world or knowledge about words, vocabulary. Those things tend to continue to increase over time. And you don't see the same sort of drop off after about age 30 or so. We as a field kind of categorize these into two different buckets. So there's fluid intelligence. That's things that rely on, speed and efficiency. Those are the things that tend to decline with aging, just as a result of, kind of wear and tear over time. Crystallized abilities are more, related to acquisition of knowledge. It's things that you can continue to accumulate. And those abilities are not really thought to necessarily be as susceptible to declines that come with aging. So let's take a look at this graph to kind of demonstrate this. So this is from a study that Dr. Weintraub did back in the 1990s with physicians. And they were developing a measure that they would test with, physicians across all age groups. When you give all of these different age groups of people the same cognitive test and you graph them, this is sort of what that looks like. So overall, there is, on average, a trajectory of decline with age. But if you look at that in more detail, what you really see, though, is that as people get older, there's more variability. So there's kind of a broader spread of where people fall around that mean performance. So this is something that's really important when you're thinking about what, kind of quote unquote normal looks like for aging, is that normal actually is pretty varied once you get into the 70s and the 80s. So this graph helps us think about kind of what the main trajectories are that we see with aging. So on the bottom of the graph, as you move to the right, increasing in age, and then if you look at the left side, the y-axis, anything above that dotted line is functioning, as normal, independently in routine activities. Once you dip below that line, there's a meaningful loss of function, so requiring assistance or even being dependent for various daily activities. So first, we'll talk about what I had just kind of mentioned. So a normal aging trajectory, the kind of average trajectory. There's some loss of cognition or cognitive performance gets a little bit lower over time, but that doesn't interfere with, your ability to carry out your normal activities, and it's rather subtle. We also have a diagnosis called mild cognitive impairment, which means that there is some observable cognitive change that people are scoring, below what is considered average for age, but those changes haven't started to really impair their daily functioning at that point. Now, when you get into that stage of cognitive changes impairing daily functioning, that's what we term dementia. Sometimes people with mild cognitive impairment do progress into a dementia diagnosis, and that's a common trajectory, but sometimes people with mild cognitive impairment also stay relatively stable over a long period of time. So this is kind of the main three pathways that I think the field has often studied or found of how aging can play out. But there's another trajectory that we've found more recently called, what we call at least superaging. So these are people who seem to have resisted the kind of average declines over time. They've maintained pretty remarkable performance and memory into their 80s, sometimes even into their 90s and 100s. And we'll learn a little bit more about that in a couple of minutes. So let's look back at this graph from Dr. Weintraub's study from the 1990s. So we saw that there was this increased variability with aging. If we look specifically at this particular subset, so there's, physicians that were over 75 and into their 80s who were performing actually on par with the youngest participants in this study. And those are people in their 20s and 30s. In this particular study, those are people who were Harvard resident physicians. So that's people who are quite academically accomplished. They're probably doing quite well on these tests. It's pretty fascinating that there are people, 60 years older than 50 to 60 years older than them that are performing just as well on those tests. So this was actually one of the things that first inspired the Mesulam Center and the researchers at the Mesulam Center to think about superaging as a concept. A couple of years later, So Dr. Mesulam, who is the founder and director emeritus of our center, had examined a brain that was from a collaborator who was building a brain bank in Miami. And typically when you look at the brain of someone who's over 80, there are some changes that you see that are associated with aging that are actually similar to, well, it's the same changes that you see in Alzheimer's disease, but some of that just tends to come with aging without necessarily cognitive symptoms. And we'll touch on that in a couple of minutes. But he had looked at this brain and he saw that there was just very little of that pathology. There was very few changes. This person had, remarkably intact cognition into their 80s. And so this bolstered this idea of maybe there's this unique trajectory of aging of people who really preserve their function over time, who continue to be, very high functioning in terms of their memory and their cognition. A couple of years later, by about the turn of the century, people at the Mesulam Center were starting to use the term superagers to talk about these people in the longitudinal studies who were showing this amazing preservation of memory. The first study protocol that was specifically focusing on superaging and using that term was submitted in 2001. A couple of years later, that program became a little bit more finalized or formalized as part of the longitudinal research registry that Dr. Weintraub's intro was mentioned at our Alzheimer's Disease Center clinical core. So this allows us to follow people over time, and ultimately many participants donate their brains so that we can study the biology of brain aging after they've passed. Science is sort of notoriously slow. So even though these steps had been made in the early 2000s, it was in 2012 that the first paper was published that specifically talked about this Northwestern University superaging group and outlined some of the unique brain signatures of superagers. So of course, it's important to know what we mean when we actually say superager. So per our criteria, what we use at the Northwestern University superaging program, those are people that are over 80 or at least 80 years old and who do just as well on memory tests, if not better, than people who are 20 to 30 years younger than them. Superagers also score within the normal range or above for tests of attention, executive functioning, and language, which are other sort of important cognitive functions. So this is to say, though, that they're not necessarily required to have better than average cognition across the board. They just have this strength in a particular type of memory, which is learning and remembering new information. This is a picture actually from the first party that was had for our superaging participants, which was over 10 years ago, covered by the Wall Street Journal. And we're actually looking forward to having another one of these very soon. But I've heard that it was quite fun. I was not there, unfortunately. So what we've learned from this very special group of people. So a large portion of the research that has, or things that have been really discovered about the superaging group has to do with their actual brains. So superaging is associated with less atrophy or shrinkage in certain parts of the brain. So specifically the anterior cingulate cortex, which is important for a host of different kinds of cognitive activities. Superagers tend to have a bit thicker of cortex in that area. They also have more von Economo neurons, which are a particular type of neuron. We don't totally know what their purpose is, but they've been hypothesized to be involved in social behaviors. They're only found in sort of higher apes and higher mammals who have social behaviors as part of their sort of normal activity. There's also larger neurons found in superagers and controls in the entorhinal cortex, which is a very important part of the brain for memory. Fewer microglia in superagers, which microglia are sort of the waste system or the waste cleared system of the brain and tend to respond to the presence of neuroinflammation, which happens along with the development of pathology. So perhaps superagers have, less pathology, there's less need to clear it out of the brain. And then superagers also show a lower density of Alzheimer's disease proteins in the anterior or the entorhinal cortex and the anterior cingulate cortex, which I mentioned, these things kind of just develop with aging in general. Superagers had fewer of those changes. There's also some clinical correlates, so not just looking at their brains, but thinking about their other sort of cognitive and psychosocial functions. So superagers also had strengths in verbal auditory attention and working memory. So their attention span is a little bit longer and they're able to manipulate information a little bit more effectively within that attention span. They also endorse greater positive relations with others. So there's at least this one piece of empirical evidence and a lot of anecdotal evidence that superagers tend to have very strong and very meaningful relationships. What is perhaps as important as finding out what's associated with superaging is also figuring out what is not associated with superaging. So superagers don't just score high across all cognitive domains or higher than their controls. So there's a specific strength in episodic memory that does not necessarily just look like, better performance across the board. When you look at a composite of known genetic risk factors for Alzheimer's disease, there weren't differences between the controls and the superagers, which means, the superaging trajectory is not just a result of a lower risk for developing Alzheimer's disease from a genetic standpoint. We found no differences in adherence to a Mediterranean diet, although this is a preliminary finding and we're going to dig more into that in the future. No differences in overall psychological well-being. So they do endorse greater positive relationships, but not necessarily just overall, feeling better or better mood. And there also weren't differences in medication profiles between superagers and controls. So those two groups took about the same amount and type of medications, which implies a relatively similar level of physical health. So it's not just that superagers are, physically healthier, and that's allowing for this better memory performance. So I think that this particular line of investigation with superagers really demonstrates two kind of distinct and pretty fascinating phenomena with aging. One of them is the resistance to the buildup of pathology. The other is actually more resilience. So whereas resistance is the ability to avoid the buildup, resilience is being able to continue to have intact cognitive functioning despite there being buildup of pathology in the brain. So I think a helpful analogy here is thinking of like a viral illness. So unfortunately, we're all very familiar with COVID at this point, obviously. Resistance in the case of COVID infection would be someone who's exposed but doesn't catch the virus. So they don't ever test positive. They never have the illness. They were resistant to developing it. Resilience, though, would be more someone who is maybe asymptomatic. So they test positive, but they don't have any symptoms. So from the outside, they might look similar, but if you really look at kind of the underlying pathology, resilience, that person does have the pathology, but they've somehow avoided the symptoms. So I mentioned I was going to do a quick aside about this sort of Alzheimer's disease. So our understanding of Alzheimer's disease has really kind of shifted and evolved over time as our understanding of it has increased and grown. Our center typically focuses on Alzheimer's disease neuropathologic change, which really defines the types of proteins that change and accumulate in an abnormal way in Alzheimer's disease that causes loss of function of neurons and then ultimately cell death. So typically, as I mentioned before, anyone over 80 has some, plaques and tangles, which are the two components that are sort of core to Alzheimer's disease neuropathologic change. But not everybody who has those changes shows cognitive symptoms. So some people who have those changes don't have any symptoms at all. Of course, if someone has, an Alzheimer's disease-related dementia, they're going to have many, many more of these plaques and tangles. But it's just important to kind of think about and know that the presence of those Alzheimer's disease changes in the brain does not necessarily always lead to observable clinical syndrome or symptoms. So the fact that it is very common for people over 80 to have these brain changes that are, a core part of the definition really of Alzheimer's disease raises this question of, is Alzheimer's disease kind of on the spectrum of brain aging? Is that how we should be thinking about this? And I think superagers do kind of add an extra layer to this, that there are actually some people who really do seem to avoid those changes. So a couple examples here to demonstrate resistance. So this is, again, the ability of the brain to somehow avoid development of pathology. So both of these cases, you can see what's graphed here is their memory scores on a certain memory measure over time. The first case, we have over 20 years of data, actually. The second one, a bit less, but we also tested them a bit later in their life. So they enrolled in their late 80s, and we tested them to age 90 before they passed. Both of these people have remarkably stable memory performance. And both of them also then, at postmortem evaluation showed pretty minimal Alzheimer's disease neuropathologic change. So again, it's pretty common. It's almost thought to be ubiquitous that over 80 people would have these types of brain changes, but these are good examples of sometimes those don't really seem to pop up, and then maybe they're not entirely absent, but they're very minimal. There were also no observed changes in either of these brains related to other neurodegenerative diseases. So they seem to be somehow resistant to pathology. And understanding why would obviously be really important for our understanding of how neurodegenerative diseases develop and how, ultimately they can be treated or prevented. So another piece of this, and I think this is actually the part that I find most fascinating, is this idea of resilience to pathology. So these two cases are here for sort of illustration and comparison. Both of them at postmortem evaluation had essentially the same levels of Alzheimer's disease changes. They had intermediate Alzheimer's disease. They also had some vascular changes, which is related to blood flow in the brain and can also be associated with cognitive changes. But when you compare them, case 3, their brains looked relatively similar under a microscope, but during their life, case 3 was very stable in terms of their memory scores, whereas case 4 had this gradual, steady decline in memory scores. Ultimately, that participant was actually diagnosed with Alzheimer's disease dementia before they had passed. So this is a person who started out super and had the steady decline that you see with the development of an Alzheimer's disease dementia. So I think, anyone involved with superaging research, at least for me, I've noticed the most common question I get is usually, well, how does one become a superager? Obviously, we all want to know the secrets. My very short answer to this, which I think is the most accurate answer at this point, is we just really don't know yet. All of the findings up until now have really been observational. They've been correlational, which means we're looking at, 2 different groups of people and we're saying, well, what's common to these different groups? What's different between them? So we don't actually know what causes what. We don't know, if these superagers are born with, thicker brains in the first place, so they're able to just maintain that over time, or is there something that they're doing? Are their brains developing in a different way? Are there, lifestyle and life experience factors that might contribute? So we don't have that formula yet. And my guess is that if we ever do figure it out, it's going to be complicated. But what we do know is that there are certain things that have been associated pretty reliably in research studies with, general benefit to brain health. So this figure on this slide here is included in the Lancet Commission on Dementia Prevention paper in 2020. I think this does a nice job of kind of laying out, if you're thinking about a specific risk for dementia, everything in the colors here has to do with, potentially modifiable factors that contribute to risk for dementia. So things like hearing loss, hypertension, social isolation. Theoretically, these are all things that could be changed to reduce people's risk. What I think is very important here is that you see that thick swath of gray where we just really don't know what the risk is. Likely some of this is genetic, some of this are things we just haven't looked into yet. But again, it's still really an open question of kind of how, one person versus another ends up on one aging trajectory versus another. So I want to also make a note just on this concept of modifiable risk factors. So by definition, technically, this just means that it's something that could be changed. Which is as opposed to something like age or genetics, which we can't change still at this point, maybe someday, but you can't change your genes. Your genes are something that you have from birth. Anything that is kind of potentially modifiable, people always pull out as, okay, this is something we can really focus on to help reduce risk. But I think it's important to look in a little bit more detail as to what these kinds of factors are. So I pulled out two components from that figure that we just saw, smoking cigarettes and exposure to air pollution. Both are associated with higher risk for development of dementia or cognitive decline and aging. Both probably have a similar biological mechanism by which that happens. They involve smoke inhalation and links to other negative health outcomes. But smoking cigarettes is, a behavior that one can theoretically choose not to engage in. Granted, that's not always a very easy choice, but it is, a behavior versus an exposure to air pollution is something that is often, it's a passive thing that's happening to you. Whether you have exposure to air pollution or sort of extreme exposure to air pollution is much more related to where you live, which is also related to socioeconomic factors. And the level of exposure to air pollution is related to a lot of systemic factors. So solving that risk factor requires a systemic and societal change. No one person can, solve that problem. So of course, we need to focus on solving these more systemic issues that lead to health disparities and disparities in risk for dementia. But I also think it's important to know and kind of focus on what are the things that are within your own sphere of influence. What can you do that, might sort of have some bearing on your risk for brain health outcomes and help you feel empowered to make choices in your own life. So this is sort of my last piece here that I'll get through, and then we'll get to questions. So I, again, like to focus on sort of your own sphere of influence here. I think it's an oversimplification, of course, to dial things down to this. But I do think, as I was thinking through these, I was noticing that they all kind of fell into these three categories. So what you put in your body, what you do with your body, and what you do with your mind. So I also want to note here, I think this is really important, that even if someone follows every single guideline that, their doctor or a scientist have told them are associated with good outcomes, that doesn't necessarily, guarantee a good outcome. It doesn't guarantee that you'll avoid the thing that you're trying to reduce your risk for. A good correlate here is the association between smoking cigarettes and lung cancer. So we know that there's a much heightened risk of lung cancer if you are a smoker, if you smoke cigarettes over a long period of time. But not everyone who smokes will get lung cancer. Similarly, though, not everyone who gets lung cancer was a smoker. So there are things outside of, the control of your own sort of personal choices and behaviors. It's possible to make every healthy choice and still ultimately experience some cognitive decline or even dementia. It's also possible to make unhealthy choices, again and again, and end up being a superager. We see that in our studies as well. So take all of that with a bit of a grain of salt that, we don't have ultimate control over outcomes like this, but these are the factors that are worth mentioning that have been shown, in multiple research studies to be associated with risk for developing cognitive decline and generally associated with promoting brain health. So starting with what you put in your body. So diet's kind of the first obvious place to start here. I'm sure that everyone here has heard from various doctors or various articles or whatever that, what you put in your body is generally, it's helpful to eat a varied diet, to eat nutritious foods. In particular, there's good evidence for the Mediterranean diet as helpful for cardiovascular health and then thus also for brain health. I'm not going to dive too much into the details here. There's tons of information online and just that you can easily access related to the specifics of the Mediterranean diet. This is a hot topic, I think, for a lot of people. There's been some mixed evidence really about, is alcohol good for you, bad for you in terms of your brain health? There's some little blips that maybe a little bit of alcohol is actually beneficial, but the bulk of research really has to do more with heavy alcohol use. That would be, multiple drinks a day. The CDC guidelines say for women, 1 or less drink a day, and for men, 2 or less drinks a day. That's obviously a bit of a simplification, but as a guideline, nonetheless. Heavy alcohol use can have very sort of immediate effects, reduces your reaction time, can make it harder to think straight, can also raise the risk of falls, which is a consideration as you age, and can have important medication interactions, which are obviously can have negative outcomes as well. Long-term damage or long-term risks are obviously more related to chronic health problems, organ damage, heart disease, some types of cancer, and even like direct impacts on brain functioning. And then smoking. So generally, smoking cigarettes is considered a risk factor for developing dementia, cognitive decline. The nicotine component of cigarettes does have some kind of immediate benefit for focus, attention, but over a longer course of time, that does also end up being associated with cognitive impairment. And then tobacco is overall associated with negative health outcomes. But it's good to know that if you quit smoking, that's associated with lower risk of heart attack, stroke, and lung disease, better blood circulation, and also reduced risk of dementia. So whether or not you've ever smoked does not necessarily, have ultimate bearing on your current risk. And then what you do with your body. So exercise is obviously something people talk about all the time. There's sort of direct benefits. Exercising can help boost cognition in a number of ways. It's also going to potentially help reduce risk for other medical conditions that could contribute to cognitive changes. Everyone always wants to know exactly what they should be doing. To be honest, I don't think there's very good evidence that there's one thing that's better than another. Really just moving your body and moving it on a regular basis in ways that you enjoy Doing what you enjoy helps because then you're going to be much better able to turn that into a habit and to engage in that regularly. And I think it can help to link exercise or movement to other valued behaviors. So things like going on a walk with friends because you get to chat and catch up, or doing yoga, Tai Chi, something that also has sort of a added mood benefit. Sleep as well is very important. I think anyone can attest if you have a really bad night of sleep the next day, you probably don't feel quite as sharp. If you have a bad night of sleep over many years, that can have, the same types of effects. So of course, it's also important to be, aware of potential sleep disorders and make sure you're getting adequate treatment for those sleep disorders. But there's general brain or sleep hygiene guidelines that can be really helpful for just, if you're someone who struggles a little bit with falling asleep or staying asleep, Google sleep hygiene habits that can be really helpful and help you get better quality of sleep. And then lastly, what we do with our minds. So you've probably heard everything I've just said before from other people related to your general health. So most of these things fall under the umbrella of things that are good for your heart health. And then that's always also good for your brain health. But what we add to this sort of in our center and the way that we recommend things to patients is we also really recommend exercising your brain and your mind. So, there's all sorts of different things that you can do. The main thing here is that variety and challenge are helpful. So it's not necessarily doing the same thing over and over again every day, but it's doing, multiple things and doing things that push you and challenge you to use your brain in different ways. These are some examples just that we've, recommended to patients that patients find helpful, beneficial. So learning new information via whatever mechanism or whatever modality works best for you. If that's reading, if it's listening to documentaries, watching or listening to podcasts, watching documentaries, taking a course, learning a new task or a new skill. Maybe it's picking up an instrument you used to know many years ago and you want to start again. Honing your foreign language skills, taking up a new craft. I also think it's really helpful to have activities that have a social component. And part of that is just because, socializing is beneficial in general for your well-being and functioning, but also other people are unpredictable. And so they add a layer of having to think on your feet that you don't necessarily have when you're playing a game or doing a task on your own. So overall, the goal is really to find a unique set of activities that are enjoyable for you and keep your mind working in a lot of different ways. And then last thing I'll mention is mood and stress. So mood symptoms, anxiety, stress can all pretty directly interfere with cognitive functioning and memory, can also be associated with other negative health outcomes. Of course, how do we intervene with these things when they arise? The first line of defense can often be, if it's truly a modifiable factor or situation, something you can address or remove, then that might be the best way to start. So that might look like asking for help with a responsibility or a daily activity that has become overwhelming. Maybe that's for physical reasons or any other reason. You're just too busy. Maybe that's distancing from a stressful relationship that's really not serving you anymore, or using technology to reduce mental burden. I use this all the time. All of my bills are on auto pay, and that is lovely, and I rely on that very heavily. But many stressors are unavoidable. They're not things that you can just change or fix, right? So in that case, it's more so important to increase your own sense of support, your social support, and build coping strategies. And that, when there are really significant mood and anxiety symptoms, the best treatment is usually a combination of medication and more talk therapy or counseling. Medication can help kind of turn down the dial of intensity of symptoms, and then you're better able to engage with strategies that are developed in a therapy context. So to sum up, I just threw a lot of information at you. Hopefully you've learned some of this and will take some of these things away with you. The main things I would like to sort of summarize and highlight are, overall cognitive aging is variable. There's not one way to age, and people end up on very different trajectories. That being said, if we look at kind of overall averages in a large group of people, most people will experience some decline in their fluid cognitive abilities with aging. Some people, though, do seem to maintain exceptional memory abilities well into their 80s and beyond. This trajectory seems to be associated with certain biological signatures. So there's something, in their brains that's different, but the mechanisms of this, the causes of this are still, unknown to us. So there's no magic formula to becoming a superager. But we do know that there are many potentially modifiable factors that have been associated with healthy brain aging. Many of those are, out of our control, require more systematic society level solutions, but some of them are things that are well within your sphere of influence. And it really breaks down to kind of what you put in your body, what you do with your body, and what you do with your mind. I want to thank everyone at the Mesulam Center, everyone I work with, staff, students, and faculty who are wonderful and why I love my job, and also the patients and families who are so generous with their time to contribute to our research and help us understand the brain better and better over time. If you're interested in these things and want to look in more detail into anything, our website is a good place to start, brain.northwestern.edu. We have some information about various types of dementia, also superaging, and just sort of general brain health information. I want to thank everyone for their attention so far. I know I threw a lot of information at you. And at this point, we're excited to, take some questions and hopefully we can address some things that have been on your mind.
Yes, thank you so much. We actually have a lot of great questions in the chat. So I'll go ahead and read the first one. So there are a lot of scientists aged 80 to 90 who are still quite productive. Is there a correlation between the profession and health and brain health?
That is a good question.
I'm sorry. I'm talking and I didn't unmute myself. I don't know. Did you want to answer that?
Go ahead.
Okay, so I don't think there's such a correlation, but I will also point out to you some superagers who have not been in our studies, not identified as superagers, but are like clearly rock and are up there, like Tina Turner, for example, people who are very active, very smart. Betty White is another person, and these people are in the entertainment industry. So I don't think there's a special link for brain scientists and superaging. Oh,
Okay. Molly, did you have anything you want to add, or can we move on to the next question?
Go ahead to the next one. Yeah.
Okay. All right. Why is there a difference between men and women in alcohol every day?
Yeah, I think that's really mostly a factor of just like body size and different metabolism. That's why it's a bit of a simplification. I think it has a lot more to do with your sort of specific health status, but that's what the CDC kind of puts out.
And will there be, or is there an updated Weintraub study?
So you mean the study that we did with physicians? So, I mean, we've been studying superagers for 25 years. The physician study really was something that was kind of not planned at that time. It was, if you must know, the Harvard health insurance, medical insurers wanted us to come up with a test that we could screen Harvard physicians who are getting older for cognitive decline, and to develop this test. And we did, and we tested it on all the physicians. And then in the Harvard system, nobody wanted to do this test. So we kind of got rid of it. But anyhow, we are studying people longitudinally. We're studying people in different aging trajectories, superaging, what we call normal agers, people who have mild cognitive impairment, people with various types of neurodegenerative diseases that cause dementia.
Thank you. The next question is, was deep sleep evaluated with the superagers? Was insomnia taken into account?
So question, we haven't really looked in depth at sleep patterns, but that's something actually that we've been talking about lately, because we do have that information, and we have some collaborators who are really interested in sleep and have studied sleep, sort of throughout their careers. So I think that'll be an area of potentially some new findings in the next couple of years.
And how do multiple TBIs affect this aging process? And have they done separate studies for males and females?
Molly, would you like me to take that one?
Go ahead.
Yeah, so I'm not aware of any studies that have compared men and women. Now, when we talk about multiple TBIs, we can talk about a normal person who in their lifetime was unlucky and got 3 or 4 TBIs. And then we can also talk about people who do very bad things for their living, like play football and getting multiple TBIs. There is this clinical entity that people are very conflicted about, which is called, now I'm going to have a word finding problem.
Chronic traumatic encephalopathy.
Chronic traumatic encephalopathy, right. And that is supposed to be a specific condition that is specific to multiple, like really severe head injuries with not being knocked out. But it does appear that having had head injuries, like in the 5 years before a dementia begins, because dementia doesn't happen overnight, it's very gradual. There are changes in the brain that are very progressive. That increases your risk if you have Alzheimer's changes in your brain for then developing cognitive loss and dementia. And that's because your brain doesn't want to be mistreated. So head injury really causes damage. It damages nerves, excuse me, damages nerve cells, and those cells don't regenerate. So it kind of reduces the brain's ability to withstand the pathology.
Sorry about that. Next question is, how does one donate their brain to the program? What is the process and who can donate?
Okay, so you cannot donate your brain unless we have been following you for years and years and years. And people, it's so important for us to understand, to actually have the experience of testing the person throughout, the 20 years before they died, so that we can understand what we find in the brain and how that's related to how they were when they were living. So just having a brain that's donated, which is this very nice thought, and I think that there are definitely some places that will accept a brain donation that don't require this longitudinal follow-up for different scientific purposes. But you really have to be enrolled in our study. Now, having said that, there aren't many superagers. We're kind of limited in our geographic locale, but now there are other places around the country that are starting to get really interested in this trajectory. So if you have any interest in participating in any of those studies, or if you're close to us, then we can help you out.
We have a few more questions. They're rolling in. Next one is, would you say over-the-counter brain supplements are good to put in your body?
We've talked about this a lot as in our center. So the problem with supplements is that they don't go through the same review and approval process that medications do. So any drug has to go through the FDA approval process, which is often quite long and bulky, but it's there to really safeguard people's safety and make sure that nothing is going to be harmful for them. Supplements, because they're not regulated in that way, don't often have to prove the same level of safety, and they don't necessarily need to show the same level of benefit. So there's just not very much research to say whether or not supplements are useful. We're sort of the mind that if something's not harming you and it's not financially a problem, then we're not going to say, we're not going to tell you no. But certainly, I think you have to be a little skeptical of supplements, especially in the way that they're advertised, that often they can be, quite expensive, and they can make a lot of money for the people who manufacture them. So that's something to keep in mind, just the way they're being marketed.
So this one is about quality of sleep. Can too much be as bad as too little? A quantity of sleep.
I'm a clinician in addition to a researcher, so I'd want to know, why are you sleeping so much? Are you over drugging yourself? Are you depressed? Are you why do you need so much sleep? Once I get rid of that, I can say that we know that beta amyloid, which is one of the major proteins, both in cognitive aging and in Alzheimer's type dementia, is cleared during sleep. So I would I would imagine if you sleep more, you'd have more clearance of beta amyloid, but there's been nothing to study that.
Right. Has race and/or cultures been involved in your study to determine superagers?
Yeah, that's a great question. Very important. And reflective of, the field of clinical research in general has historically had a really big problem with having representative samples in their studies. So people who are from minoritized groups in a variety of ways are less likely to have the ability to participate or even be interested in participating. And that's, there's many reasons to understand why that is the case. Our sample, starting out was relatively small, so we didn't have a whole lot of ability to address, more nuance between different cultural groups or different racial groups. As that has expanded, that's much more of a focus of really trying to cultivate a sample and study population that is more representative and can actually, answer more nuanced questions about people's experiences.
Okay, so this will be the last question that we may have time for today. So you mentioned alcohol, but what research has been done on cannabis regular daily use?
That's a good question. I mean, a lot less. It's historically been very difficult to study cannabis because of the way that our research approval system works. I think there have been, I actually don't know if there's any direct research on cannabis use in older adults and sort of direct risk for dementia, but there can certainly be negative impacts on memory functioning in younger adults if they're using cannabis, heavily, regularly. But I would say that's still an open question and probably something that people are studying, but not something that we have a good sense of yet.
Yep, and we have one more question. So this one, so she play games every day, such as card games, solitaire, and word help with brain health. She has history of Alzheimer's in her family, and doctors have told her to play games to keep her brain active. I guess she wants to know, does the games help?
Yeah, so this is a great question and one we get, all the time because people really are interested in how can I prevent or mitigate risk that I might have, genetically or from other factors. We don't necessarily have evidence that any specific game or even like specific type of game would necessarily be more beneficial or not. I think that there is evidence that staying cognitively active in whatever way that really means for you does help with preventing decline. So, again, the variety and sort of the level of complexity and novelty with different cognitive activities definitely matters. So, honestly, working full time is something that's going to be keeping your mind nice and active. I think, in a situation where you are already pretty cognitively active, if adding in those additional kind of brain games, that kind of thing is stressful, or it's honestly making it harder for you to kind of have relaxation time or do other things that are important, like exercising, that kind of thing. It's really a balance between kind of overall maintaining your physical health, but also, allowing yourself to kind of craft a balance between activities that are really enjoyable for you, that do push you and challenge you a bit, but not to the point where it's just, becomes overwhelming or is sort of more harm than it's worth. So, it's not going to hurt you, I guess, is also what I'm saying. And as long as it's not causing you stress, those things are likely good, but I would recommend doing different kinds of activities. So not just doing, the crossword every day and only doing that, doing crossword and other word games or visual puzzles, like really kind of diving into different types of activities is what we tend to recommend.
Thank you. I think that was a great question and answer to end this wonderful webinar, Molly. But thank you so much for taking the time. That's it for questions now. And on behalf of Health Services and the library, just want to say thank you for speaking to us today and giving us the great experts discussion.
Of course, Dr. Weintraub had to pop off because she got paged, but I'm sure she would also share her appreciation for inviting us. And we love talking about this. This is, you know, I could talk about this all day. So always happy to.
Yes, thank you so much. And it was nice meeting you, and we appreciate your time today.
Thank you.
All righty, have a good evening.
You too.